It's truly an honor to be able to give this lecture. And in terms of Dr. Bosniak, obviously many of you know him, but I thought I would show you a picture that was given to me by one of his students. And if you look really hard, that's 1962 Montefiore. I think I was playing shortstop Little League in Coney Island, but that's Dr. Bosniak. And this resident at the end here is Dr. Stan Siegelman. And Stan Siegelman introduced Dr. Bosniak in one of our courses a number of years ago as if radiology was a family, Dr. Bosniak, who taught him from the beginning, would be his father. And I was going to give the next talk, and he said, well, if Dr. Bosniak is my father, then Elliot, here's your grandfather. And just wanted to remind him there's 10 shopping days till Christmas. If I describe Dr. Bosniak's career, this is probably a great quote from George Bernard Shaw. And if you look at Dr. Bosniak's work, particularly in the kidney, some men see things as they are and say why. I dream of things that never were and say why not. And that really describes a lot of his writings. And all of us use his work on a daily basis. So in saying that, it's a privilege to be here. And what I'll try to do in my time today is really look at CT of the kidney from a vascular perspective, from CTA, where things are going. And I think one of the things we recognize is there's tremendous capabilities these days, more than ever, for valuing the kidney. Regardless of our capabilities, our ability is related to how we do the studies. Scan protocols from phase of acquisition to slice thickness to scan spacing is critical. And also the concept of CT being an axial mode is something that's really disappearing. CT is truly volume visualization, and a critical thing in terms of imaging will be this ability to look at volumes. Now, in terms of doing and creating the protocols, we recognize there are lots of different opportunities, lots of different options. And of course, if radiation wasn't an issue, when you think about the phases of acquisition, you probably would do 5 phases on every patient. But radiation, of course, is an issue. So what we try to do is do the phases that are necessary to make the right diagnosis and do the study correctly the first time. And we'll speak about that today in detail. The way I like to look at the kidney really is from a perspective of functional imaging. And instead of thinking about renal masses or inflammatory disease, vascular disease, just think about how the kidney looks depending at the time you look at the kidney. So we'll divide things into 3 phases and then look really at what their advantages are, what their disadvantages are, recognizing that every phase does have its pluses and minuses. So we think about 3 phases: corticomedullary phase, roughly 30 seconds out; parenchymal and nephrographic phase, around 60 plus to 90 seconds out; and excretory phase at 4 or 5 minutes. So we focus on corticomedullary phase, and I would say that's probably the phase that's most controversial, but it's a phase we've always had a lot of interest in. The thing about this phase is you have that corticomedullary interface best defined. The cortex is maximally enhanced to around 150. The medulla enhancement is relatively low at around 50 or 56 Hounsfield units. So you have about a 90 to 100 Hounsfield unit spread. And it's really the best phase for looking at anything that relates to perfusion. Anything that changes the corticomedullary interface, whether it's infection or tumor, whether it's ischemia, anything that changes that interface will be best defined in most cases at this time. So anything that relates to vascular change, and as we know with CT going from 4 to 16 to 64 and beyond, so much of what we do really relates to this vascular process, and so it is indeed a very critical phase. Now there are pitfalls, and as I mentioned in the beginning, not every phase is perfect for all things. And a lot of articles, particularly when spiral CT first came along in the mid-90s, spoke about how corticomedullary phase imaging had significant pitfalls, particularly that masses might be missed, smaller lesions at the corticomedullary interface, and indeed that's possible. The problems with pseudo-enhancement, the problems where lesions may appear to be benign, yet are cystic malignancies, or the reverse. And again, the possibilities of having problems picking up smaller lesions. But most of that issue was really 1995 in that early spiral CT era. And in these days of 16 and 64, there really is typically not the same problem. And also the reality is we would never recommend only doing a corticomedullary phase acquisition. So we would do that phase plus typically an excretory phase. So it's typically not an issue. So let's look at its advantages. Well, one advantage is just looking at perfusion. So if you take a look at this case, this patient has aortic dissection which involved in part the renal artery. you can see very nicely the differential enhancement between the right and left kidney on the axial images. You can see the intensity of the cortical medullary interface is far less on the left than it is on the right. Renal size has not significantly changed, at least on that axial imaging, but you recognize the perfusion changes. And when you take those axial images and you put them in a coronal display, it's even more obvious. So one of the important things to recognize, a lot of the things that relate to perfusion of the kidney, a lot of things that relate to cortical medullary interface are really best defined outside the axial plane. So in all our dedicated kidney studies, we always provide the information beyond the axial plane, coronals, NPR, 3D, whatever we do, and we'll look at many of those applications, but it's critical to recognize that many of the visualizations are best seen outside that phase. And also from a global perspective, you're able to look at perfusion because in this case, the difference in perfusion is the entire left kidney. In other situations, it'll be portions of the kidney. Another example, again, dissection, again, the difference between the enhancement of the right and left kidney. And you see that a bit better on a 3D volume acquisition. And when you start looking a bit closer at this case, you recognize that the difference in perfusion is in a sense in both kidneys. The right kidney has good perfusion for the upper 2/3, but if you look carefully, the lower third really is not as well perfused, and the left kidney is kind of the reverse. The upper 2/3 have decreased perfusion, the lower 1/3 has relatively normal perfusion. And if you look at that a little bit more carefully, you recognize the reason is because the patient had 2 renal arteries to both kidneys. On the right, the lower pole renal artery came off the false lumen. On the left kidney, the main renal artery came off the false lumen. So you can very nicely see as we've gone from volume rendering to MIP that the MIP really accentuates the visualization. So one of the things we do find with 3D imaging in the kidney, it accentuates differences. Those things that seem to be subtle really aren't as subtle. And here's a good example of that. If you look at this kidney, this patient had hematuria, if you look very quickly on the axial views, it was actually read as negative. You look at the coronal views, look at the lower pole of the right kidney. If you look very carefully, the cortical interface is not as sharp, there's decreased enhancement, and it's subtle. But if you take that same case and you put it into a 3D map, volume rendering on the left, MIP on the right, look how much more obvious, particularly on the MIP, those perfusion changes are. So a lot of what we're able to do with cortical medullary phase imaging is because we go beyond the axial display to look at these changes, which again can be very subtle in axial mode, but very obvious in 3D mode. And in terms of cortical medullary phase imaging, of course, it's not just arterial changes that have impact. In this case, we see subtle changes. The left kidney is a bit larger. The enhancement is not as intense as the right kidney. The cortical medullary interface is there, but it's relatively poorly defined. And when you look a bit more carefully at this patient had a partial thrombosis of the left renal vein, seen nicely there, and seen nicely there on the 3D reconstructions. So again, vascular changes, arterial or venous, will cause changes in the cortical medullary interface. I show you this example real quickly, the same patient. Here's the MIP image, here's volume rendering. To remind you that when you do 3D imaging, you want to be careful with MIP because with partial thrombosis, you'll actually lose that partial thrombosis on a MIP image because MIP is a projection technique. If you want to see the thrombus, you need to be within the volume. And those changes are true regardless of the cause of the patient's renal vein thrombosis. Beyond arterial and venous, things that cause obstruction, whether it's stones, whether it's in this example where the patient has decreased, the right kidney is enlarged, the change in cortical medullary perfusion on the right side is very easy to define. And then the question is, why is it? Well, you look carefully at the renal pelvis on the right, and you look at a few more images, and you see evidence of patients having tumor masses in the renal pelvis and had other masses in the patient's ureter. This patient had multifocal transitional cell carcinoma. So one of the things you recognize is the cortical medullary phase, by showing you changes in perfusion, allows you to then look carefully as to the cause, whether it's arterial or venous or potentially obstructive. And here's one more example with a larger mass in the right renal pelvis. Again, the intensity is decreased compared to the contralateral kidney. You see the infiltrating mass. We go to the volume rendering and then go to the MIP where you see the vessels are stretched, but there's no real neovascularity. Very classic for a transitional cell carcinoma. You look at perfusion changes for a range of causes. Patients with hypotension post-trauma or post-op, again, the perfusion changes are really best seen in the early phase. You can see whether the perfusion changes from infarction are segmental or, in this case, fairly global. Again, the early phase shows you very nicely the differential enhancement of portions of that patient's left kidney, where most of the kidney has really absent perfusion. Again, the typical thing is multiple renal arteries, one occluded, one still getting perfusion. And here it is showing you that same process within a 3D volume rendering. So again, the ability to visualize the kidney goes far beyond simple axial imaging, but you need to take advantage of that when you look at the different phases. Or in this example, this patient was post-op from an aortic aneurysm repair, and you very nicely see the lack of cortical medullary interface on the left. Here it is another view. There's really no definable enhancement at about 30 seconds out in the left kidney. Here it is on the excretory phase views, and we'll speak about excretory phase a bit later, and you see the enhancement of the capsule vessels giving the rim around the kidney, and you can see that very nicely looking at early and late phase imaging, very classic for an occlusion of the renal artery. And here's the 3D map. You can see the left renal artery was occluded as a surgical complication. Again, the visualization of those perfusion changes allow you to make that diagnosis. Or in this case, another patient with aortic aneurysm repair with a focal infarct in the lower pole of the patient's left kidney. So again, one of the things we also recognize in terms of renal imaging, particularly in post-op patients, is the importance of early phase imaging and the importance of contrast. You're not going to visualize, of course, changes in perfusion unless you're giving IV contrast, and often just getting late phase imaging may not be enough information. Other applications in terms of early phase imaging, the question about renal trauma, changes, subtle lacerations, as in this case, are very easy to recognize in the cortical medullary phase. In terms, of course, of contrast extravasation from the renal pelvis and calyces, you need excretory phase imaging. This is also the ideal phase in renal trauma if you're looking for the presence of pseudoaneurysms, of course, or looking for active extravasation from arterial structures. We know that 85% of renal cell carcinomas are hypervascular, and we'll touch on that a bit later. But one of the other important things that cortical medullary phase imaging gives us is the ability to look at the vascularity, not just saying a lesion is hyper or hypovascular, but looking at neovascularity. And one of the important things, I think, as CT goes beyond 64 to dual energy, will be the ability to look at perfusion, look at neovascularity, and from that determine aggressiveness of tumors. And there's some articles now that have been published that basically say that you could determine how aggressive a tumor is based on its vascularity. And unless you do cortical medullary phase imaging and look for those areas of AV shunting, you're not going to be able to visualize it. Here's another example. This is a case literally we did about a week ago. Here's a coronal display. You see some of the vascularity. You see it here on a volume rendering. Here's a little bit better display showing you the neovascularity. Here it is on MIP, and MIP is the ideal visualization when you want to look inside the kidney to look for neovascularity. And again, you can compare the volume and MIP, but it's an excellent way of looking at neovascularity, and that's very important in surgical resection. Can patients get partial nephrectomy? Obviously, this patient could not, but also I think looking forward with this whole new chemotherapy, anti-angiogenesis factor, and the like, becomes very critical for us to be able to understand how these tumors indeed behave. In terms of lesion detection, comments about cortical medullary phase not being ideal typically are not really true. Most renal cells, 85% we commented, are hypervascular, and here is the lesion again on volume and MIP imaging. Here it is on a coronal display. One of the things to recognize, of course, that some of the pitfalls, I think, in looking at smaller lesions particularly relate to the fact that it's an axial display rather than a 3D display. And I think even from the multiplanars through the 3D, the ability to visualize makes it much easier. This also is a good example maybe of a central scar with an oncocytoma. I'm about 100% accurate for diagnosing oncocytomas because I always diagnose them after the pathologist tells me that's what it is. Because reality is most oncocytomas in renal cells, you shuffle them. In most cases, they look pretty close. Now, we recognize, of course, non-contrast CT has value in looking at renal masses, particularly for being able to diagnose hyperdense cysts. We also recognize that a non-contrast scan is very limited in terms of detecting smaller lesions. So one of the things, of course, we all recognize, patients with hematuria get a stone protocol. We're always careful to comment that we can exclude an opaque stone, but we really can't exclude a small renal cancer as a cause of hematuria. And here's just a simple example. As we look at the best phase for this renal mass, you can see on the cortical medullary phase, you do visualize the patient's lesion right there. And I would agree it's relatively subtle, but still is pretty easy to visualize. But I would say that on the excretory phase, it's a little bit easier to see. So one of the things to recognize, of course, is that lesions are typically seen on both phases of acquisition, or all three phases of acquisition if you do a 90-second acquisition. The one phase may be better than the other. So there are select cases where the excretory phase is really optimal, and so in our practice, we'll always get an excretory phase. Not to mention, of course, when we speak about the pelvis and calyceal systems, without an excretory phase, you'll miss transitional cell tumors. One of the reasons I think that people commented about missing hypervascular lesions, like in this case, that's fairly subtle maybe, and maybe you can walk by it if you were just quickly zooming through a stack of images. But when you go beyond the axial mode, you see this lesion is much more obvious in a 3D display. So one of the things, as we commented before, is you need to routinely visualize the kidneys beyond the axial display. And if you want to optimize detection, you need to be beyond that axial image. Now, in saying that, sometimes it's just not going to help. Look at this case. Does everyone see the renal cancer? Well, I'll give you the right kidney, and I'll give you the upper 2/3 of the left kidney. What about right there? Well, boy, that is really hard to point that out there. And this is probably the example you speak about where a lesion that's a 1 centimeter of the cortical medullary interface is very difficult to visualize. This was a 1 centimeter renal cell. Patient ended up with a partial nephrectomy. And this is the example that really does tell you that you need to get multiple phases. And here's one more example where there's a cystic lesion here with enhancement. Again, it's probably very subtle. Again, here it is in coronal display. Even there it is kind of subtle, particularly when you take that image and you go from there to there. Here it is again, right there. But sure, a lot easier to look at on excretory phase imaging. So again, I think the point is well taken that there is issues potentially with certain small lesions in the cortical medullary phase. But again, when you get both phases, you're going to get the best of both worlds, lesion classification as well as optimized lesion detection. It's also important to recognize that sometimes the early phase will be the only phase to show the tumor. Here's a 1 centimeter renal cell cancer, very well identified, easy to visualize. And here's the same patient with excretory phase imaging. It's a little bump there, but that lesion would not be recognized. It literally became isodense. Isodense renal cells are fairly uncommon, but they indeed do occur. The other issue with early phase imaging is in pyelonephritis. And the classic signs that Dr. Bosniak described about striated nephrograms, that's an excretory phase finding. And so it's not surprising that in select cases, if you only have early phase imaging, it's very easy to potentially walk by early pyelonephritis, which is very obvious on late phase imaging. In most cases, it's not really the case. Here's an example, early phase imaging. You see the differential enhancement. You recognize the patient's acute pyelonephritis. But in select cases, you will miss pyelonephritis. There are many ways to miss renal disease. We showed you examples of wrong phase of acquisition, the comment about how we visualize through plane of acquisition, and also with poor post-processing techniques. Now, this is a good example showing you what happens without doing early phase imaging. This is a patient who presented with hematuria, and there was an outside CT that read a renal tumor, a transitional cell, right about here. Patient went for cystography, they put a stent in, they biopsied the lesion, came back, was bleeding like crazy, biopsied a couple times, stopped biopsy, sent him to CT. The question is, what is that lesion? It looks like a mass. I would agree it looks like a transitional cell if you only look at the excretory phase imaging. There's a soft tissue mass, compare it to this parapelvic cyst. What's that lesion? Well, when you did the early phase imaging, that's the lesion. It's an AV malformation. And that's not what you want to be biopsying, let me just say. And you can see it very nicely. Here's the early draining vein, but it's only visualized on the early phase imaging. And here just showing you a number of different visualizations. A very obvious lesion that is not very obvious, impossible to diagnose. So again, to optimize detection, whether it's tumors or it's a vascular process, you really do need the early phase imaging. And I've now seen about a half a dozen cases where it was vascular pathology mistaken for renal tumors, and they've been biopsied or have undergone workups for something that was obviously not a tumor. Okay, nephrographic phase. We'll change phases. That's 60 to 90 seconds out. Cortex and medulla enhance equally. You don't have any excretion of contrast yet. Typically, the enhancement of cortex and medulla is around 120 Hounsfield units. Here's just a simple example. Again, the question, you see smaller lesions, smaller cysts potentially. I guess that's been shown to be true in some earlier articles. But I do admit that you get much more information looking at the cortical-medullary interface than you get on when the cortex and medulla are the same density. There are certain advantages, but that phase is good for looking at the renal vein, let's say, in renal vein thrombosis, or looking for venous extension by tumors. But in terms of lesion detection and characterization, I think it does not offer a lot. We therefore tend to then focus on the excretory phase. Again, the literature, 3 to 5 minutes is typically excretory phase. We go at around 4 or 5 minutes. It's really the phase, of course, that's critical for looking at the renal pelvis and collecting system. You're not going to pick up small transitional cell carcinomas, of course, unless you get excretory phase imaging. It does have potential pitfalls. Now, one of the things about CT, for many years, it was hard to get urologists to stop ordering IVPs, even though CT was so much better. And you know the story, negative IVP, get a CT, positive IVP, get a CT. Well, one of the reasons I think that people or urologists felt they couldn't leave the IVPs is they were so used to looking at the IVPs and that visualization. The way we finally ended up getting rid of IVPs was going to CT urography. So when you acquired the excretory phase imaging, it was not enough to simply show axial excretory phase images. That would not cut it, but you need to show everything in a 3D display. So the volume visualization allows you to look at the kidneys, the pelvis, calyceal system, ureters, and look at it through a range of perspectives, of course, and do that interactively and provide the urologist with all the information they're classically used to. So in our practice, we routinely will do that and send those images to the urologist. In terms of protocols, we'll talk about that a bit later, but in about 90% of cases, you're able to opacify well the renal pelvis and proximal 2/3 of the ureter, and the lower 1/3 in about 70% of cases. Even in patients with obstruction, of course, you can see the ureter because it's dilated, and water or urine makes a great contrast agent as well. But you see very nicely the changes, in this case of pyelonephritis in the left kidney, the atrophic kidney, thinning of cortex, blunting of calyces, or in this example, renal tubular ectasia. One of the things, and one of the reasons we scan it about 4 or 5 minutes out rather than 7 or 8 minutes is my feeling is that if you wait too long, the contrast becomes too dense in the pelvis and collecting systems, and in that situation creates a lot of artifact. So when you try to do the volume rendering of the pelvis and calyceal systems, the quality is not very good because it's too dense. So one of the things to be careful about is not to have the contrast too dense. So waiting longer is not necessarily better. And you can see in this case multiple small polyps within the pelvis and collecting system, very nicely defined. So you can see the visualization supplements the early imaging. The comment about looking at axial imaging alone is nicely shown in this example. Look at the left renal pelvis. I think you should be able to recognize that there is something infiltrating into the pelvis here, but I would say it's fairly subtle. You don't see the calyx showing here well, and we look at multiple images, but it's a little bit subtle. But if you take it into coronal, you see a little bit of soft tissue here, stretching of the infundibulum. Again, you see that here, so you're questioning what's going on here. But if you take it into a 3D map, it's much easier. Now you see the stretching of the calyces. You see an infiltrating process sitting here. We'll target down on that a little bit. You see it very nicely here. Here it is again. We'll show you different rendering techniques. One of the things you can do is to do a reverse ramp which allows you to look inside the pelvis and collecting system to get very nice visualization of that infiltrating tumor. So again, the capability is just simply changing the rendering parameters, allowing us to visualize, really gives us significant detail. So a critical component of expiratory phase imaging is this presentation with CT urography. In saying that, so what do we do on a routine basis? What about non-contrast CT? I think the advantage of non-contrast CT and why it's important is not so much for detecting stones. You do early phase imaging, you'll see all the stones as long as the kidney's not excreting contrast. So that's not the issue. I think the issue is these days we see so many high-density renal cysts, typically cysts in the range of 50 to 90 Hounsfield units. And the way to make that diagnosis 100% is knowing that on non-contrast CT, early and late phase imaging, the lesion does not change. It measures 50 Hounsfield units at every point in time. So non-contrast is very critical to kind of get our bearings, to understand specifically what the original density is, and then we'll select the other phases depending on the situation. There are many ways to think about timing the different phases, from bolus tracking to test bolus to uniform delays. In our practice, for most patients in renal imaging, we use preset delays, try to inject 4 cc's per second of contrast, go around 100 to 120 cc's. Borderline renal function will drop the volumes to 80 cc's or even 60 cc's if necessary. Since we are thinking about displaying information as a volume, it really defines your protocols. So from non-contrast CT, the sections are thicker, typically 3 millimeters. But when we go to the other phases, we'll do the thin sections, typically 0.75 millimeters by 0.5 on a 16 or 64 slice. On the cortical medullary phase, we'll only scan the kidney. We used to scan through the pelvis, but really the additional information typically was minimal, and we want to minimize the dose to the patient. And then nephrographic phase, if we do get it, we'll again do the thin sections. And expiratory phase will be the phase that we cover the entire pelvis and bladder, ureter, and the like. So we'll try to really optimize our information, yet minimize the radiation dose. Protocols, depending whether it's 4, 16, or 64, we go with the best collimator we have on a 4 slice. It's a 1 millimeter collimator, 1.25 millimeter thick sections at 1 millimeter interval through all the phases. At 16 slice, 0.75 by 0.5. Again, very important because the volume acquisitions. And at 64 slice, we're typically also going at 0.6 millimeter detectors, but 0.75 by 0.5 millimeters is our typical acquisition across all phases, recognizing that our urologists expect to get 3D mapping on all of the cases where they have dedicated studies. In saying that, the information you generate is critical. From the arterial mapping, so we know there's lots of variations in arterial mapping. Articles have shown CT versus angio. Even at 4 slice was nearly 1-to-1 in terms of detecting critical vessels. At 16 slice, we compared this to a surgery in laparoscopic donors, and basically it was 99% accurate. At 64 slice, you're just not going to miss any small vessels. In terms of being able to detect vessels, yes, you can scroll through the data sets, and I would agree that if you were very careful and looked at every single slide, you would be able to pick up all the renal arteries that were present, but it would take you a whole lot longer than looking at it in 3D mapping. A 3D map makes it very easy to recognize the number of renal arteries. Whether it's MIP or volume rendering, there's no difference in terms of detecting the number of renal arteries that are present. Again, particularly when it's complicated mapping, multiple renal arteries, prehilar branching, it's very obvious to recognize what's going on, 3 renal arteries and prehilar branching here on a 3D image, MIP and volume rendering, where if you were looking at the axial imaging, you might have significant more difficulty. We also recognize that prehilar branching is incredibly difficult to ascertain on axial images. You can overcall or undercall. Accuracy rates are in the 50%, while on 3D imaging, it's basically 100% for doing that. You also recognize that even if you are very careful, there are times you'll miss small renal arteries. Here's an example. Look at the left renal artery. You see the main renal artery. There's a little tiny structure just above it, which is a second renal artery. And I'm not trying to hide it here. This is the best I could do to kind of show it. There it is there. Very easy to miss, of course. And the reason I saw it is because on the 3D map, you can find here's the main renal, here's the second renal, which is sitting just behind it. Again, could it be prehilar branching, but it was no, it was a separate origin. But it was very obvious on the 3D mapping, on the axial images, even in retrospect, very difficult to diagnose. Multiple renal arteries, we commented, again, axials are fine, but we also said prehilar branching, you're just not going to visualize on the axial display. So in terms of throughput, in terms of accuracy, it again makes the point when you're looking at vasculature, you need to be within the volume. Again, in terms of technologies, creating 3D maps, that's one model people use. Our experience is you have to do the imaging yourself. The way workflow is going to go in the future is you're going to look at 3D imaging interactively, and then you'll supplement that by looking back at the axial images. But it's really the only way to be able to do that very quickly. Or in this example where it's prehilar branching, but you can see how close the vessels arise to each other. And again, this might be confused on axial imaging with two renal arteries. And this prehilar branching was critical because this was a potential donor, and because it's very difficult to cross-clamp, they, instead of doing the left kidney like they typically do, they went after the right kidney, which had two easy-to-define renal arteries. You can see some of the changes due to prehilar branching nicely in this case. This patient had a partial nephrectomy that went bad. You can see they infarcted a good portion of the kidney. This portion of the kidney is enhancing because when you start looking carefully, it's fed by a prehilar branch. So you can see the importance of prehilar branching. If the surgeon does not recognize it, early on the experience with doing laparoscopic nephrectomies for donors, there was a lot of issues with renal infarction because small branches that were critical. This is a 2 millimeter branch, yet it's supplying 25% of the blood flow to that patient's kidney. So very critical to recognize that. In terms of renal artery stenosis, CT is very good in detecting and quantifying stenosis. One of the issues of CT over the years has been quantification. It's still an issue. It's true in the carotid, it's true in the coronaries, it's true in the renals. There are tools being developed that allow the computer to quantify the amount of stenosis that's present. Volume rendering is more accurate than MIP, but unless you're very experienced with volume rendering, you can create critical errors in either overcall or undercall disease. Here's a nice example of a soft plaque in the patient's proximal right renal artery, showing you that both with volume and with MIP. And again, both cases show very nicely a very high-grade stenosis at that point. So what we'll typically do is when I'm looking at the potential for stenosis, I'll always look at the volume, I'll look at the MIP, and I'll look carefully at the axial images and curved planar reconstruction. Another example here is plaque, small calcification as well. Again, volume rendering MIP, looking at a high-grade stenosis. It's also important when you look at stenosis, and here's another example, when you try to quantify not to use one perspective only. Again, on a single view, you can overcall or undercall stenosis, so you need to review the images around 360 degrees, and you can see from this perspective, you really get a feel of how severe that stenosis was. So again, one of the big advantages, of course, of 3D processing with CT is this global perspective. You're not limited to a single visualization. You can see that in this example. You look at the left renal artery, there may be a little bit of narrowing, but it doesn't look very impressive. If you look at the kidneys not enhancing as well. The coronal display, a little bit of narrowing. But look at the 3D map. Look how nicely you can see the stenosis. Here's opaque volume rendering. Here's volume rendering versus MIP. And you can see very nicely the stenosis proximally defined. So in terms of being able to accurately detect stenosis, define, and quantify, you need to be outside that axial plane as well. In terms of MIP versus volume rendering has been shown to be more accurate, but as I commented, there is some variability in terms of users. There's also variability in terms of workstations. One advantage, of course, of volume rendering compared to MIP is that you don't need editing of the data set, so that indeed can also potentially help your workflow. In terms of CTA versus MRA, there have been several articles looking at renal artery stenosis, no significant difference, although patients tended to prefer CTA. In terms of patients with borderline renal function, we could do fairly good 64-slice renal artery studies with 50 to 60 cc's of contrast. So typically, we can lower the dose as necessary. We can look at stent patency. Again, stent patency, renals, carotids, coronaries are a very big potential application for all of us. The key thing, again, is looking at a range of visualizations. The MIP or the volume rendering nicely show you in this example the patient's renal artery stents, but it really doesn't show you, and it can't really show you, is the stent patent or not. The curved planar reconstructions where you open the stents up are a very nice way of looking. You give very accurate detail, and the accuracy is in the high 90%, looking at stent patency as well as quantifying degree of stent stenosis. Some of the stents, particularly some of them have high-density metal, which creates more artifact, but most of the renals tend to work very nicely in terms of that application. Other details, things like fibromuscular dysplasia, just a couple comments. One of the things where CT was felt to be very weak was in detecting FMD. The classic string of beads was often difficult to see, but if you look at the articles published, the latest article really was on a 4-slice scanner. So you really didn't have the ability to look at the type of detail to look at this information. And you can see here was the article published in 1999. That was a 4-slice system. There's been no more recent data, but here's just a simple example. Look at the patient's right renal artery, and I'll just show you 4 sequences of images. Classic string of bead appearance. 64-slice CT, very easy to make that diagnosis. So again, whether it's stenosis, whether it's fibromuscular hyperplasia, easy to define. The ability to visualize the vessels in detail allows us to pick up small renal artery aneurysms. More commonly these days, routine pickups. Often they're underestimated on the axial images. When you go to a 3D map, it's more obvious the presence of aneurysms, both in terms of size, feeding vessels, whether you need surgery or embolization. And here's just 4 examples of incidental renal arteries, from those that are calcified to those that are not. And we do pick those up on a routine basis these days because of the fact we're doing routine 3D mapping. And even this largest aneurysm, which is just about ready to rupture, that's sort of an atypical renal artery aneurysm, but one that presented in a patient with hematuria. Or in patients post-trauma, this was a child who had a sled accident about a week earlier, increasing flank pain. They thought it was due to maybe a urinoma. We did early phase imaging, and you can see very nicely on these volume rendered images this patient's renal artery pseudoaneurysm, and here it is with volume and MIP, which was then embolized a couple hours later. So again, that early phase, critical for vascular visualization. Same thing in terms of renal venous anatomy. Variations are very common. Most of the time they're not important, but with laparoscopic surgery, particularly for donors as well as nephrectomies, they become much more important. Classic venous anatomy, 70 seconds tends to give you a very good visualization without any issues related to flow. And you can see it very nicely here. Variations from retroaortic renal vein, which is very common in this visualization, or a very complex circumaortic renal vein. In this example, you can see why most surgeons will not do patients with circumaortic renal veins for being donors. Often the lower pole vein comes very low, in this case coming at the level of the aortic bifurcation, so there's no way the surgeon could really maintain vascular control. It's just too long a distance between the renal veins, and our experience in circumaortic renal veins is the gap is somewhere around 4 to 7 centimeters in most cases. And here's just one more example of duplicated renal vein, which then goes retroaortic, very low. Again, this would not be a case of a patient who could be a donor, at least from that left kidney. We also visualize the gonadal vein routinely. There's a large variation in terms of gonadal vein size and importance. We do see it routinely in terms of cases like this where the gonadal vein is fairly large. Often it can be bilateral, commonly associated with pelvic congestion syndrome, but in many cases, and in fact most cases, it tends to be an incidental finding. There have been several articles in renal donors looking at the importance of the gonadal veins. Most of the articles will conclude that it's just an isolated finding, as in this article, though others have concluded that it can be very important, that in retrospect, patients after they donated a kidney actually recognized that they had prior symptoms which had disappeared. So there's some controversy, but most of the time it's just simply an incidental finding. Renal vein thrombosis, again, that phase at around 70 to 80 seconds out tends to be an ideal phase. Partial thrombosis is more commonly seen these days, in part because of better resolution. Classically, we would see total thrombosis of the renal vein. Now we see often partial. Most of our cases tend to be patients with tumors where they're spread into the renal vein, but we recognize there are many different risk factors. In terms of the visualization of renal vein thrombosis, as in this example, from the axial views, as long as you can go along the vessel, you can see it very nicely. At times, if you're at 30 seconds out, you have a pseudo lesion, particularly in the right renal vein, so you want to be very careful calling a renal vein thrombosis at 30 seconds out. And here you can see very nicely, when you do the reconstructions, it really shows the extent of renal vein thrombosis, and again does show you the patency of the vessel around the clot, that it's just a partial thrombosis. In terms of tumors, whether it's renal cell or transitional, CT with 64 slices is basically one-to-one with what the surgeon will find in terms of spread. In this case, a transitional cell carcinoma, infiltration into the renal vein, and then up into the IVC. So CT is very accurate for defining the extent of renal vein involvement as well as IVC involvement. And here's another example with very extensive involvement. Often with hypervascular tumors, the clot within the renal vein will also be vascular. So that's important to recognize. The question at times is it thrombus, bland thrombus versus tumor? When you see vascularity in the renal vein, then you recognize it's tumor. You also can see very nicely the extension from renal vein into IVC into right atrium. So again, when you're staging patients with tumors, it's important to scan high enough that you're able to cover the entire area, that there is thrombosis, you know exactly its superior and inferior extent. Chronic renal vein thrombosis is a bit less common. At times it can be subtle, and this is a good example. The left kidney, the enhancement is not as good as the right, but it's subtle. But start looking for the left renal vein. Well, you end up, when you look very carefully, the renal vein is really atretic. You can see it's a chronic thrombosis. You see other signs. You see collateral vessels. Things like perirenal cobwebs, collaterals along the ureter are all signs of revascularization. And in this case, there's subtle changes in the enhancement of right to left kidney, but they're there. But the key finding are the vascular changes as well as the chronic renal vein thrombosis. And it's very much like thinking about the liver with portal vein thrombosis and cavernous transformation of the portal vein. We visualize all the collaterals. And here's another nice example which shows the collaterals along the ureter. Sometimes there's confusion. People worry about a tumor of the ureter or infiltration of the ureter by metastasis. And again, you want to be very careful. When you go from the axial to the coronal 3D display, those problems are indeed often solved. And again, it's fairly uncommon. Classic nephrotic syndrome may be the presentation, but the presentation indeed can be very variable. And with chronic renal vein thrombosis, the classic thing really is those collaterals that I showed you. Let me make a few comments about CT urography in terms of how we use it. I commented before the importance in terms of our practice, the importance in terms of how we deliver information to referring physicians. And again, you can see a good example in this case where there's an infiltrating tumor in the renal pelvis. You recognize it axially. It shows nicer on the coronal display how it fills in the calyx. You can see it here from coronal to 3D volume rendering. You can see nicely here the display with the cutoff of the lower pole calyx. And here it is coned down. Here it is axial on the excretory phase. And then you look at that in 3D maps. Now, there have been a number of articles looking at how we should do CT urography. Some people use compression. Some people give Lasix. There are many ways of doing it. We tend to do it a fairly simple way. We give the patient a large water load about 20 minutes in advance of the study. That tends to hydrate them well, and then we'll give them contrast. We'll wait 4 to 5 minutes, and then we'll get delayed scans. Ideally, what you'd like to do is, before you get the final images, have the patient rotate on the table so the contrast gets mixed up, and then you get very nice visualizations. Compression paddles, are they helpful? They can be used. Some articles have found them helpful. Giving patients Lasix, you could do that, but it becomes more complicated, and I haven't seen the gain. And here's just some simple examples. So one of the key things, of course, we commented, visualization. Here you're looking at the ureters like they're classic IVPs, very opaque. And then we'll change it to where the ureters and pelvis are transparent. This transparent projection works very nicely for looking for smaller polypoid lesions. It's a much easier way of visualizing them. Also, potentially, it's better for looking at the papilla. But again, that's not been proven in any large series. Whether it's mildly dilated calyces, which you can see very nicely here, or mildly dilated pelvis, or in this case where the calyces are dilated, where the patient has scarring in both kidneys, particularly the left kidney, but also the right kidney, in a patient with chronic pyelonephritis. When you go from the early phase imaging to the expiratory phase imaging, we very nicely see the calyces, the blunting, the thinning of the cortex, and again, the visualization that makes that indeed a very easy process to do and to quantify. Whether it's things like ectopic ureter seals, I mentioned that 90% of the time we can see the proximal 2/3 of the ureter, distal ureter about 70% of the time, and you can see very nicely the bladder. If you want to look at the bladder, giving IV contrast really is not good enough. If you want to get detailed views of the bladder, we'll put a Foley in the bladder, then drip in up to 500 cc's of saline mixed with 30 cc's of contrast. Do that under gravity. That's the ideal way, whether it's a trauma situation or in looking at patients with suspected tumors. Giving IV contrast and then waiting 8 or 10 minutes is just not going to distend the bladder enough. So you really need to recognize that. But ectopic ureter seals, as in this case, very well recognized. Whether it's this example, look at the filling defects in the bladder. Look at the upper pole of the right kidney. That's a renal cell carcinoma with hemorrhage in the bladder. Or this example, this patient had hematuria, and this was read as negative. I refilmed the case. Look at the right kidney. You see that little, looks like a P in the right renal pelvis? And it's a very, very subtle. It's about a 5 millimeter structure. The way we recognized that was not on the axial images, but we recognized it on the 3D, where you really can see the filling defect right there. Here was very, very obvious, and that was a 6 millimeter papilloma when they removed it through a ureteroscope. Again, the 3D visualization showed that very nicely, something that was totally missed on the axial display. One important thing to recognize when you look at the literature, here was a recent article talking about CT urography for looking at renal tumors, talking about how the 3Ds were not very good for visualization of tumors. You need the axial imaging. I wouldn't want to say that we don't look at the axial imaging, but I think what you have to think about is doing everything together. In this article, the other issue was, forgetting the fact that it was 4 and 8 slides, but the issue was that all of the images were generated by technologists. And we have the best technologists at Hopkins, but there's no doubt that if you want to read a CT of the kidney, you don't want to be reading the 3D maps that were generated by somebody else. It's not the technologist. I wouldn't look at the 3D that was generated by one of my other radiologists at Hopkins, and they're, of course, never miss anything. You have to look at the images yourself, and I think one of the critical things in this whole visualization concept, you heard Alec Megabo this morning talking about the pancreas in that regard, it needs to be an interactive process. So when you look at the 3Ds of the kidneys, you're looking at the MPRs, you're looking at the axials, you're doing an integrated approach. Getting 3D images from somebody else and saying 3D is not accurate is probably a very much unfair statement. A lot has changed over the years. A lot has changed over the time Dr. Bosniak's been in radiology. The changes really have been the last few years in terms of CT. The greatest, the changes in terms of how we practice, how CT impacts. 2 references. Here's one talking about 3D mapping for urologic surgery. In our institution and many institutions, Surgeons will not do partial nephrectomies or classic nephrectomies without 3D CT staging in advance. The ability to define, detect the extent of disease, the ability to be able to show all the information in a single comprehensive study is critical. We recognize the point about radiation dose to patients. I think one of the best ways of decreasing radiation dose is to do the study right the first time. And if you maximize the information from that examination, it's not an issue. The biggest danger is to end up with 3 different studies, an IVP, 1 CT, and then a follow-up CT for more clarification. Then you really increase the radiation dose. A single study done the right way the first time really decreases radiation dose. And I think in terms of urologic imaging with CT, it's a good quote. It takes a lot of unspectacular preparation to get spectacular results. How good you are, how good your accuracy is really dependent on your protocols and techniques and visualization. The right protocols, the right visualizations, the right timing and acquisition will really increase your success rate to near 100%. With that, I'll stop and again, thank Dr. Bosniak and the NYU staff for inviting me, and it's truly an honor and a privilege. I gave the opening session in RSNA, but this is a far bigger honor. Thank you very much.